Hi, welcome. House Healthcare. It is 1 o'clock, April 7th, Tuesday. Thank you, everybody. Thank you for your patience. I'm sorry we're running a little bit behind. And we are starting this afternoon on S-197 because we have Blue Cross Blue Shield with us today. And I want to give a apology slash I'm not sure for the rest of the week. We are flip-flopping from bill to bill all week long. And it is strictly sort of a matter of timing and when certain witnesses could be here and when other ones couldn't. So I'm sorry if it's all a little disjointed, but in the next hour, we're going to be talking, or 30 minutes, sorry, 30 minutes. We're going to be talking about S-197. And we have with us Courtney. Courtney, are you coming up? And Tom, I think you're on.
I hope he's still there.
He was there.
Sounds like he's back.
Okay. You would have been really disappointed if it was just me. So.
Hi, how are you?
Good, thanks. Sorry about that. My connection dropped me.
That's okay. So.
I'll kick us off and then I'll just kick it to Tom if that works. For the record, Courtney Harness, Blue Cross and Blue Shield of Vermont, thanks for having us. And I would say thanks for all of the work that's gone into all of the testimonies so far on this bill. I think probably haven't been able to catch all of it, but what I have heard has been really valuable and really important. So appreciate all the work so far. Dr. Weigel is with us. He's our Chief Medical Officer, and I'll ask him to go through some of our internal quality efforts that we're currently offering, as well as a presentation that he shared previously with folks from the Blueprint and with AHS. So I do want folks in the committee to know this won't come as a surprise to anyone operating in those areas. They've heard this from us before, but want to really reiterate what we think are the primary focus areas of the bill. So we do think it's important to increase in our spending in primary care, understanding that doing that without also increasing premiums just means a little bit of a shift, investing in primary care, shifting money from another business line. And I don't think that has much to do with the committee other than to say that is a thing. Another thing that we think the goals and objectives of this bill could really work towards is reducing administrative burden for providers. And one of the ways that we see this coming to life through this bill is streamlining all of the various different ways that quality programs and other provider payments are currently existing. And Dr. Weigel will walk us through some of that. And then I think lastly, things that we all agree on, trying to figure out ways to improve quality access and affordability for folks. So, Dr. Weigel, I will turn it over to you.
Oh, Leslie already has a question.
Yes.
Primary care spend, and
Yeah.
we've been hearing data about what percent of, your payments, I suppose would be the word, I don't know, is in primary care. Can you make that distinction? Do you know? And could you, yeah.
Yeah, I think, Dr. Weigel, can you answer the question about our overall spend on primary care as a percentage of our full book of business? I want to say it's close to 9.
I'll have to take that as a takeaway.
Yeah, that's tough because what do you consider primary care? So you may not be able to figure it out, and I understand that too.
Well, I was going to ask that question, and I haven't let you get into your testimony yet, but wasn't that question asked by the Green Mountain Care Board during insurance rate review this year? And so what?
Would have been 2024. So we would probably use our 2025 spend to update you all if you'd like, or I can.
Okay.
Get the.
Okay. I vaguely I feel like I saw something around 5 point something %.
Yeah,
I'll have to check.
I don't have it in front of me, and I don't want to guess. I do know that we, for our community providers, for the primary care providers, we spend about 70% on fee for service, and the rest on either fixed or value-based payments.
Okay. I'll let you keep going with your testimony.
Okay. I am going to request to share.
We have these slides, Dr.
You'll get
Waterfall.
sorry, I haven't sent you the slides.
Okay, you haven't
but
sent them yet.
You do have the one pager.
Yeah, I can.
You'll get the slide.
I can send these as well as the
That's
testimony.
just helpful to follow along.
Sure. So, I think Vermont does have a strong primary care foundation, but the way we pay for it isn't really fully delivering in outcomes, accountability, or affordability. So what I want to walk through today is a path to really modernize reimbursement by building on what already exists and aligning incentives across the system. As far as the problem we're solving, primary care is still underfunded, I think as Courtney said, relative to the role that we expect it to play in managing population health. At the same time, payment is still too reliant on fee-for-service, which drives volumes rather than value potentially. And then across the system, we don't have strong alignment between state programs and payer models. We have multiple care coordination resources that aren't fully integrated. So I think the opportunity here is to modernize reimbursement in a way that strengthens access, aligns payment with outcomes, improves accountability, and maintains affordability. As we think about modernization, these principles are important here to keep grounded. This is still about patient-centered, team-based care with strong integration across physical health, mental health, and community resources. We want to be data-driven, improve access and equity, and align across payers to reduce the provider burden, which we've heard about. And the key addition here is strengthening the link between payments and measurable outcomes. I'm not going to purport to be the expert on Blueprint, but they have created a statewide primary care infrastructure through medical homes and the community health teams. And Blue Cross Vermont has been a major contributor over the years, over $90 million invested just from Blue Cross Vermont alone. It's working in terms of participation and coordination within the Blueprint, but really where it needs to evolve is around measurement and accountability, clearer outcomes, more standardized metrics, and stronger connection between what we're paying for and what we're getting. So the opportunity is to modernize how we're paying for primary care so it's more measurable and value driven. I guess this is a way that I've been thinking about it that's been helpful for me, the concept of payment buckets. At a high level, primary care payment can be thought of in 3 buckets. And importantly, Blue Cross is already operating in all 3 of these buckets. The first is fixed or prospective payments, things like capitation, and this supports access and population health management. The second bucket, these are variable payments or value-based payments where we tie dollars to quality and performance. And then the third bucket is fee-for-service, which still pays for the individual encounters, and incentivizes access to some extent. The key here is not to build something new, but to really rebalance how dollars flow across the buckets over time. For the value-based portion to work, we need a real clear and aligned set of measures. These are examples, not anything that's necessarily been agreed upon. These should focus on core functions like prevention, chronic disease management, mental health integration and management, and it applies to both Medicaid and commercial population, including adults and children. And the goal is to move toward a consistent statewide framework so providers know what to expect and they can make changes in a meaningful and actionable way. Another concept here is primary care tiering. I know that the Blueprint does this already. And when I showed this to John Saroyan at the Blueprint, he said, well, your tier 2 is actually our tier 1 right now. But maybe don't focus as much on that, but the fact that For Blue Cross, our value-based programs include all the community providers. We send measurement outcomes to 113 different community practices, and they don't need to be Blueprint. We use the Blueprint attribution to attribute our members to practices, but that's, I guess, what I would describe as maybe foundational. The provider who has basic access, maybe it's just one provider in a group, but I don't want to leave primary care providers out of this incentive. But if we can tier this model so that each tier has more advanced services or higher quality, I think that would be really helpful. So as a practice moves up the tiers, they receive higher levels of fixed or value-based payments, and it really creates an incentive or pathway for capability development for these practices.
Can I unfortunately, I don't have the benefit of having your slides, so I don't know if you're gonna get to this, and I don't want to interrupt you, but I kind of want to go back. You just indicated that you provide information to, I think you said 100 and some practices, providers, information. What are you sending them? What are you providing them right now?
Sure, we have a program, value-based program for primary care providers, community primary care providers, called Enhanced Community. You call it ECPC, Enhanced Community Provider Incentives. And so we have, I think there's 11 different metrics on there. There's some quality metrics around hypertension and diabetes control. There's a total cost of care metric. There's an incentive for referral patterns to lower cost settings like imaging or lab. And being a commercial payer, we have risk gap closure incentives. And so each of those metrics has a range and a threshold. And each of those metrics has what we call a PMPM, or a per member per month payment attached to it. And so if a provider meets or exceeds the threshold, they get the per member per month payment for that metric. And so looking down, we can send you a sample of the scorecard, but each provider gets a scorecard that shows where they are according to the threshold, above, below, or at. If they're at or above the threshold, the payment amount that they get for that. And then also there's a little dots for their peer practices, so they can see how they measure up against their peers. So they might see that they met 6 of the 11 metrics, and so that adds up to, it can be a total of $6.30 per member per month. So maybe they get $5 PMPM. And then they can also see where they might be close or need to make some improvements, let's say for diabetic control of their patients. So Courtney will make a note of that, and we'll follow up and send you our scorecard on that.
I'd be really interested in that. And I'm just wondering, has Blue Cross Blue Shield done any analysis on whether or not all of these metrics have had an impact on the health of their members? And also, I'm wondering, naming off some of the measures that you just listed, I'm thinking about things, like referring to lower cost lab. That's not really a quality thing. That's more of a saving Blue Cross Blue Shield money thing.
Well, it's saving our
I'm
members
thinking
money,
about-
yes, but that's, yeah. So there are some things that may
You
not.
said total cost of care.
Right, yeah.
Well, does Blue Cross Blue Shield do any analysis as to why some practices may not be performing as well as others, based upon, their population, based upon social determinants of health in the areas in which they serve, based upon the...
Yeah, so all of our metrics are risk adjusted for level of, illness and such. So, age, so that we risk adjust that by practice.
Okay. That would be really interesting to see some of these.
Yeah, so I have a note to send the scorecard and outcomes that we've seen.
Perfect. Thank you.
And I may, if it looks like this is going pretty quickly, I may be able to actually pull up the scorecard if we get through this and everybody has time. This is focused a little bit more on specialist collaboration. And so another opportunity is to really strengthen how primary care and specialists work together. With prospective primary care funding, PCPs can manage more care directly and use specialists in more of a consultative way rather than making a referral and handing patients off. This includes things like e-consults or defined co-management pathways, or back in medical school, we'd call them curbside consults, where you could talk with the specialist and make sure you're on the right track. For payers, this keeps care on the lower cost setting, oftentimes reduces unnecessary referrals or imaging, improves access to specialists for patients who actually really need to see the specialists. So there'd be a broader shift from referral and handoff to consultation and co-management. And this would be built into either or both the capitated payments and the value-based payments.
Can I ask
Sure.
Can I ask a question about that? Are the coordinating or the consultative specialist, are they financially rewarded for how they work with primary care in this model? Who benefits in this model?
So that's something that would need to be worked out, whether there's something they would be billing as a code or whether there's a different sort of agreement. But this for me was a little bit of a newer concept. So this is something that would need to be kind of sussed out and designed. But yes, I mean, I agree. You can't just have a bunch of specialists on call and not expect them to have some sort of remuneration for that.
I guess what I'm asking is, are they being judged? Are they being rated in any way? I mean, it seems like this is a two-way street here, and I'm wondering, are they being measured on their access as well as on the other side?
I hadn't seen that as part of the incentive. So for example, there might be 3 or 4 specialties that we might want to focus on, for endocrine for, diabetes, cardiology for hypertension, heart failure. And so practices that would have kind of working agreements with those specialists may receive a higher, incentive or capitated payment. And then the idea would be that they'd be able to, the primary care providers would hang on to those patients more than not. An example was I got a colonoscopy and I had some polyps, which luckily were benign. And my GI doctor who did that colonoscopy wants to see me every single year until he does the next colonoscopy 5 years later. Not doing any scans in the interim, but my thought was, I don't need to see you. My PCP can get the report, and please hand me back to my primary care provider. So I think the idea is trying to incentivize the PCPs being able to manage the things that they can pretty easily manage or manage with some consultation.
I think Daisy had a question, and then I see Leslie has a question as well.
Hey, Tom, good to see you. Alyssa was asking about whether the specialists who are partners are guided by any, or what they're measured by or measured on. And I noticed you have a bullet that to me reads that they are measured on the same things that the primary care providers would be measured on. The bullet on the left in the green box, second from the bottom, says that the PCP specialist partnerships supported by shared outcome measures align incentives around cost, access, and quality. Doesn't that mean that they're on the same outcome measures?
I think the idea would be to have some care pathways for some kind of critical things that we're trying to focus on. And that's certainly a good idea. And this is a bullet point, and this is also still a bit of a big work in progress. So I think that's certainly a takeaway that
And
I will.
we don't do this now. This is an idea. So this isn't
Oh.
something that we operate. This is something that we'd like to see.
Okay, so this
Yeah,
has not been.
Sorry, right.
Concept,
Correct.
okay.
Yeah.
Leslie?
And I'm just thinking about how do you operationalize some of this? Like you talked about a lower cost lab. In a business primary care practice, sometimes it's not easy to figure that out for that particular person. What's the expectation of a primary care practice to do that? Or maybe you haven't gotten there yet, but I worry about that.
Sure. So I know that, for example, we're working with the practice that was sending all of their patients to one facility that had very high lab costs. And we worked with them and Quest Diagnostics to actually have somebody, a phlebotomist, come on site to draw labs and to work things through Quest. And the cost savings will probably be millions of dollars for that practice in particular. So Quest is willing to work with other practices. And Quest isn't the only solution, but sometimes it's also a matter of just informing patients and saying, we used to send people here and you can go there, but your labs are going to be, 2 or 3 times more than if you go here. And I see you have a high deductible plan. So some of it's, there's what we call shoppable services. So, if you're not in the ER, you can shop where you get your MRI or your CT scan or your labs oftentimes.
So who's responsible for shopping?
So I think it's a system responsibility. We have shoppable services price lists that we've sent out to primary care practices that they can, post on their walls or office doors or put in their waiting room. That they can talk with patients about that. The patients then too have some responsibility if that's of interest to them. We also have a cost of care website where patients will log on using their ID, and so we know their plan, we know their deductible, we know how far along they are in their deductible, so we can give them an estimate of what something might cost at certain sites.
This is feeling kind of burdensome to me, both to the practices and the patient. So that's my worry. Is supposed to be shopping to get the best price. Yes, we want to get the best price, but the system wants to get the best price and not put the pressure on the patient and or the practice. That's what I'm worried about.
Can I ask?
Yeah.
Do you think Blue Cross Blue Shield has a responsibility to negotiate the best prices? I mean, ultimately, if something is a higher cost setting, you've negotiated those rates.
Yeah, so we're in the process of 2027 hospital negotiations now, and we've put some pretty aggressive proposals forward, particularly on lab and radiology, capping lab at 300% and radiology at 500% of Medicare rates. And it's, at least for the 6 PPS hospitals, it's about a $100 million cut. And it's about a 20% reduction in outpatient costs. Now, I'm not sure where we're going to land. Some of the hospitals of the 14 are obviously critical access hospitals. I think one of the PPS hospitals is potentially on the edge of insolvency. So we've put these proposals forward to each of the hospitals early in the year, so we could potentially build them in our rates and they can build them in their hospital budgets. But that's our working proposal for now. I do think that ideally it's would be nice if people didn't have to shop, and if the reference-based pricing went into effect, so that in the coming years, so that you don't have to shop as much.
Yeah, I appreciate you saying that you wish people didn't have to shop. We should be able to get the care we need when we need it, at a price that the system can afford. Yeah, it's hard, it's dense.
It is.
Yeah, I mean, I'm only just gonna say, having practiced in primary care, that there are times, and you mentioned Quest. And there are times that, well, Quest is the only one you can go, but their hours are this, and they're working, and they can't make that, and therefore they can't use with the most local lab, and it becomes really burdensome. And I'm worried, I guess I feel worried about it.
Thank you. You want to, I'm not sure how many slides you had left.
I just have two, and then I could also pull up, I could try to find the scorecard too.
Great.
This is just about care coordination. We need to better align care coordination. Right now, we have multiple resources, community health teams, payer, case management, other practice-based teams. And there's definitely an opportunity to align these into a more coordinated model with clear roles, shared care plans, and better communication. We really need to track better activities across these realms and measure the impact so we understand what's working. And this really just lays out the work that needs to happen. We need to define the payment model, how dollars move across the three buckets, and how the tiering works. We need to align measures and tie them clearly to performance. Obviously model the financial impact and make sure that we're focusing on affordability and viability of the practices. We can't count on, I think one thing that Courtney said, we can't count on theoretical reductions in healthcare costs. We're going to have to ideally move current spend from elsewhere into primary care so that the rates don't go up because of this. We need clear governance, strong expectations, but ultimately the goal is to align the payment, the measurement, and the care delivery in a way that strengthens primary care while maintaining affordability. Let me just go see if I can find my.
May I just, because we had this conversation in here the other day, and I'm just stuck on this. Why does primary care, in order to be paid for the services they're providing, why do they need to prove that you just said we need metrics to see if it's actually it has savings. Why do we only discuss return on investment in regards to primary care? Why aren't we talking, why are we not making anyone else responsible for population health? Why aren't we making other specialties? And why aren't we making hospitals responsible for what the return on investment in their health service area is, or the urologist being paid for the quality of care and having to, I guess I don't understand, you're paying all these additional things, this per member per month, and then fee for service this, and then there was a blueprint of this and that. Why don't we just pay them more? Why don't we just pay them why don't we just pay them for the services they're providing? I'm sorry, this has been like a week-long.
Yeah, so I mean, it's a good question. I think if you just pay them more with fee for service, you can incentivize utilization over quality and other metrics that we'd like to see or we'd like to get better. So I think that's why you add the variable quality based, outcomes based payments to that's the second bucket. And then I think the idea of capitated payments is also just paying them. So pay them per members, per attributed member. Each primary care doctor gets a payment. So you get a fixed payment. You can also get a fee for service payment, and then you also get a value-based payment. So I think it's, you know, it's a way to incentivize different aspects of what the providers do.
How do you measure value?
How do you measure what's not measurable?
Well,
You,
some things are measured. So here's our scorecard. Let me see if I can.
no, it was, what is meaningful is not measurable. That was from Dr.
Yeah, I guess the larger question is, what does valuable care mean? What is the definition of valuable care? What makes it valuable?
You know, I think-
Valuable to who?
well, you know, we spend a lot on healthcare in this country, and we don't have outcomes that other developed countries have. So, you know, short of universal healthcare, you know, I think working to have programs like, you know, this what I'm sharing, you know, these are things that we can measure. We know that when people are taking steroid inhalers more so than rescue inhalers, that they have better outcomes. So this is the scorecard that we have for our enhanced primary care project, that all community providers get this report card. The metric here is listed on the left. The percent payment threshold is listed in the next column. The provider score is just past that. And then this bar graph here, the black dot is actually the payment threshold. The brown is what that provider scored, you know, above or below or at that metric. And then you can also see some of the peer practices here. So, for example, asthma medication ratio, breast cancer screening, we know that that's important and improves outcomes. Colorectal cancer screening, kidney health evaluation for patients with diabetes, adult immunization status, initiation of substance use treatment, a wellness visit percentage. The gap closure is more specific to a commercial plan, total cost of care. And then we're working on CPT2 coding billing, which makes it easier for us to measure things like blood pressure and diabetes control. So for this provider specifically, they met the metrics on the far right column in green. That's the per member per month payout, 80 cents. And then if there's a gray box, that means they did not meet the metric. And then this is the total per member per month payout. So if they have 1,000 members, that's, you know, $4,400 times 12 months, maybe close to $50,000. So this is what that provider would receive for these value-based payments with these metrics. I don't know if people have questions.
I guess I'm just seeing on these lists of measures, I'm seeing a lot of patient engagement rather than true quality of care that a provider would. I mean, my doctor has been reminding me for the last 2 years to get a mammography, and I keep forgetting because I'm in Montpelier half the time. That's not my provider's fault. Yeah, I'm just perplexed that we have created a structure in which we have relegated one specialty to curing all of societal ills.
And pay
So
them
can I
less.
Yeah, I'm sorry, I have Karen and then Daisy, and I'm probably gonna, I'm gonna censor myself.
And it does seem that the weight of responsibility is on this relatively underpaid or under-resourced specialty. It has this great responsibility. So one question in terms of what is quality is access part of what is quality. Like there are plans in this state where you get 3 primary care visits for free every year. What if that were integrated into every plan, every copper, bronze, silver, whatever metal grade, and everyone got to see their primary 3 times a year without any expense? Can that lead to
Okay, I
just
mean,
access.
any preventative care visit is zero cost share for members.
I'm sorry?
I said any preventative care visit for members is zero cost share.
I have to, I'm sorry, I said I wasn't jump in. As a former biller, people conflate preventive with considering everything at primary care as preventive. One preventive visit means nothing except an annual exam, which if you have a diagnosis for anything other than just you are a completely well person receiving screenings, that is no longer a preventive visit. So yes, everybody, because it's a US Preventative Task Force recommendation, everybody gets a free physical. But that's, I'm sorry, I don't want people to think preventive care is free. What is free is you get a physical once a year.
And does that meet that? I mean, is that a?
And that, you know, that is not following up on your 6 chronic conditions. It's not, you know, your high blood pressure and your diabetes and it's not that. So I'm sorry to interject. Go ahead, Karen, and then.
Appreciate that. No, I'm just thinking
I'm just-
access, and thank you for that clarification from your experience. That's all.
So my point was going to be around primary care bearing the burden of demonstrating value and good outcomes. And I have to say I disagree. I think it makes sense because we've built this system so that there has to be someone in charge of someone's health plan, right? And if you don't have a plan, what are you doing, right? How are you going to stay well? And you work with your doctor to determine what you need to be well and stay well. And that's your plan. Someone has to coordinate the plan. It's not going to be my neurologist. It's not going to be the specialist. And they have their own outcomes. And it's, you know, to hopefully not have Daisy in there and on medication for 10 years, but to move me through and get me well on their neurology path. But my primary care provider, I think someone has to have the global view. And I think that, yes, they're drastically underpaid for it, but there's also folks, our mental health providers who are paid a fraction of what primary care providers are. So it's, I don't know, it's difficult hearing that primary care providers are underpaid too, when it's really so many people in our system, so many people, and they don't have the tools to do what they're charged with doing, like managing a person's treatment plan. If you don't have the technology and the tools to coordinate, it's kind of hard to demonstrate outcomes. But I think, you know, the outcome is that you have a healthy person, right?
It's, well.
I'm just
I mean,
confused by
the question, I guess the question would be for Tom, not necessarily me.
I might just,
Consider the.
just to, because I know we had talked about wrapping up, but just to say, I think we agree, right? We agree with the overall goals and objectives. Take away some of the administrative burden, get more money into providers for whatever the reason, to providers themselves for their salary or to the practice. And also make sure that people have more access with more quality that's more affordable. I think all of those are the same. And I probably should have level set with the committee before Tom did his presentation, that there's a lot of stuff in his presentation that we don't actually do right now, but things that we would see as beneficial given the nature of the bill to potentially incorporate, so that some of those things that need to be streamlined get streamlined. So they're easier for patients and Vermonters, so that it's easier for providers, and so that we can achieve some of the goals and objectives. I don't begin for 1 second to believe that it's an easy pathway, but we have to, I think our opinion is we have to start to put some things out into the ethos that could move us in that direction.
Just a clarification for me, Dr. Weigel. I think I said that right? you were looking at what you were measuring, and one of them seemed to be asthma treatment with steroids, or maybe a steroid combination to prevent.
I think
That
it
was the top one.
Asthma.
Excuse me, what did I say?
I think it was inhaled steroids.
For asthma. Yeah, for asthma. Thank you. Does Blue Cross Blue Shield pay for those inhalers?
Yes.
Thank you. But sometimes it's hard for people to get those, so that may be through other places.
I think there was an issue a year or two ago with the asthma inhalers, but I'm forgetting what
Right.
it was, but I think things got sorted out with that.
Oh, great. I'm so happy to hear that. Thank
For
you.
kids. That was an amendment on 216. Like, wow, my PTSD through this whole conversation.
Yeah.
Modifiers and, Alan.
I think I heard a few of the positive things you just said. What are, if this bill passes, what are some of the negative things?
I think the things that we said are positives can also be negatives, right? I think the expectation to double our payment into primary care, we're fine with. And you heard me and Dr. Weigel say, if we want to maintain premium levels without them increasing, we'll take that investment from somewhere else and put it into primary care, and that's incumbent upon us to do that. Okay. And then maybe I would say also trying to streamline things to reduce burden becomes overburdensome.
Okay, my second question to that is, and I'll use myself as an example. I have Medicare, Blue Cross Blue Shield, and if you go with this system here, and I pay a set amount per month, is this going to be extra other than what I pay Blue Cross Blue Shield for my premiums now?
Oh, this is us paying. So not.
That's you paying.
Right.
Will we be paying an extra fee as patients?
I think the idea is this is where it gets a bit complicated. I mean, what I'd say is I'd like to take some money from other areas of healthcare spend, let's say specialty or hospital, and move that into primary care. So we're redistributing so that change does not itself impact, our rates or what the patients are paying. That being said, when I say specialist, almost all the specialists in the state are at hospitals. And so now we're going back to hospitals, hospital budgets, hospital negotiations, Green Mountain Care Board orders. So a lot of this gets a little complicated because I'm essentially saying, let's take money from the hospitals and move it to PCPs. But there's a lot of, history and other impacts behind that. We've been meeting with all the hospitals. A lot of the critical access hospitals feel like they're kind of on the edge of going under, and we certainly don't want that to happen, and want to make sure we're kind of judicious in our negotiations with them. So it's complicated, and we're willing to do all we can to move things toward primary care.
Thank you.
Thanks.
Oh, go ahead, Val. I just sent a note to Val because he usually raises her right hand and I'm like, no, I'm never gonna see it.
Hi, thank you. So regarding your report cards, it's kind of a compound question. And I don't know if I read it correctly. I'm curious, meet benchmarks. Is it a monthly report card? How often is that report card?
I believe it's quarterly. And what we'd like to do is to have it, I think it would continue quarterly, but we'd like it to have more metrics that change kind of each month or each quarter. There's some metrics that are called essentially HEDIS metrics or quality metrics, and those come out yearly. And so it's a little more difficult if we're paying on a metric that changes yearly. I'd like a practice to be able to make changes today and see a change in outcomes in a month or two. So
another part of the question, do you think sound disrespectful at all, that system could possibly give primary care the incentive to pick and choose their patients on certain levels to meet those benchmarks? And would that give you a misinterpretation of what the population in that community would be on a more realistic basis? That makes
So
sense.
what, I mean, personally, I don't see a primary care doctor kind of firing somebody because their diabetes is not under control. But, we do risk adjust the metrics. So if a practice has generally sicker patients, that would be accounted for in the metrics.
Thank you.
Daisy, I know, I was thinking of a question that I had actually.
Is Blue Cross measuring providers or doing anything similar to this now, or is this a proposed added?
Scorecard is what we do now.
Okay.
Yeah.
Okay.
And we also we have a one pager that we sent to the committee. So those are our current value-based programming. So we do right now 6 million to the group, and then we spend about 3.2 on our internal quality programs with our providers. And then I made a list, so the committee knows I did make a list of all of the stuff that we asked for, so I'll make sure we get that sent in.
We can send information on both those value-based programs and outcomes, and also maybe a note on the risk adjustment, because I know that's come up a couple times.
Thank you. And not pertinent to your testimony necessarily, but I would be doing an injustice to everybody who has sat in an office like me, appending a CPT2 code to report on a quality measure. That is a biller sitting in an office, spending their day opening charts, looking at someone's A1C and appending that CPT code. That is, what did you just say? Well, no, he had said something before and I'm like, oh. Okay, anyways, thank you.
That's one more, just add.
Sure.
I'm with you on the, I get what you're doing here, that you're evaluating full reimbursement for the primary care. But I'm just worried, because I think a lot of people are dropping their insurance. There may not be people on a primary care right now, and they're going into an emergency room, and that's who they're seeing as their primary care, and then probably going off to see a specialist. And I think we're missing a piece here, and it's scaring me that we're asking primary care providers to go above and beyond to prove that they're doing what they're already doing, and it's a system that's broken, and we should be rewarding them instead of saying, please do better at your job so we'll give you more money. And it's just, and then to me, when a primary care physician sends somebody to a specialist, we're looking for a really nice warm handoff. Like if you go to see a pulmonologist, we had a physician in here that said she knew they had COPD. They went to a pulmonologist who diagnosed them with COPD, put them on the inhalers, and it was a long ways for them to go. But the pulmonologist said, come see me in 6 months, and 6 months, and 6 months, when it's hard to get in to see a pulmonologist to begin with, when the primary could definitely treat this patient afterwards. And it seems like a warm handoff would be for the pulmonologist to then say, let's do telehealth and keep this patient doing well. And that could be the incentive for both the primary care physician and the pulmonologist, that would be like a warm handoff where both could be rewarded for good patient care for both of them. And it's a win-win for everybody, especially the patient. I hate that scorecard. I did. I looked at that and I'm like, that is like asking them to do more than what we're already asking them to do for a lot less money. And that bugs me. Just gonna say that.
Thank you.
But can I ask a question?
Yeah.
How else do you know that your provider is delivering evidence-based care, right? Like those things that are on the report card are things that have been shown to make people healthier, right? And so how do you know?
Because they're licensed providers
So they would do it anyway.
and they took an oath.
That doesn't mean that they're gonna take that approach though, right?
Then they shouldn't hold a license.
Yeah.
Or they
You know,
need,
I used
the whole system needs to be,
Yeah. I
like
spent a
you
lot of
said,
time-
universal healthcare. Let's like, Brian's not here if he's listening. Yay, Brian.
I spent a lot of time working at a psychiatric hospital, inpatient, residential, partial hospital. I can't tell you, I would say 5 or 6 out of 10 patients would come in on 5 to 8 medicines. And do you know how they were started? 2 were started today, 3 were started a few days later. They didn't start them, ramp them up, wait to see if something was helpful. They'd start another medication for side effects rather than adjusting the first medication. There's people who just don't practice good medicine out there. There's people, probably, I don't know who don't do well at managing diabetes or hypertension. I don't manage those, it's not me. But if we don't have some quality metrics, I would not assume that every doctor has been trained and practices good medicine. We've audited mental health records that I think were just absurd. They didn't even ask about safety. They didn't, people don't necessarily practice good medicine. I don't think the takeaway should be that we all went to medical school and we all know what we're doing.
To the scorecards.
Do you know what the average wait time is currently for adult psychiatric consultation?
I don't have that on the scorecard, no.
And do we know that the scorecard actually changes practice?
We do have outcomes, which I've got a note to send.
Thank you.
I'll follow up. We got a lot of stuff to send in. Thanks very much.
Thank you.
Yeah.
Sorry if I got a little emotional there. It's just,
No, I'm sorry if I literally
thank you.
3 PTSD triggers today.
Well, I had practiced 3 PTSD practice triggers today.
We are moving on. Oh, I'm sorry. Did Brian?
No, he
Okay.
didn't have a question. I thought he had a question.
We are moving on to S-163. So we did last week, we had it last week for a possible vote, and then it was the feeling of the committee that we really wanted to sort of hear what is happening in real practice, and we wanted to talk about the concerns that the Board of Medical Practice had, where they said, well, you would at least like to see this. And so Devin is here to share with us, like, sort of protocols on, like, what is the experience of people that are hired in these positions and practicing in our hospitals, sometimes not under supervision, but yes, thank you.
Devin Green, Vermont Association of Hospitals and Health Systems, and you brought up supervision, which is interesting, because I think that's a little bit at the crux of the issue here. And I have set out the sort of education, residency, training requirements that each physician, APRN, and PA have. This is just taken from the Board of Medical Practices testimony, just so you have it in front of you. But I think what you can see here is that PAs and APRNs are very similar when it comes to the hours of training and that sort of thing. I think the difference that we have in Vermont in this moment is APRNs have the ability to open up their own practice once they do these 24 months and 2,400 hours of training and, extra training if they have an additional role or population focus. So at that point, they can open up their own practice. Physician assistants are unable to open up their own practice on their own. What they have is a practice agreement with a physician but it's not supervision. The physician is not liable for the PA. It is essentially consultation when needed, which that's what happens in a hospital anyway, regardless of if you're an APRN, PA physician. And I think because all of this is solely limited to a hospital setting, that it does make sense to have physician assistants in line with the APRNs in this bill, because we're not talking about the outside setting of someone hanging a shingle or anything like that. We're talking about this within the hospital setting, and I would say that the roles are very similar in the hospital setting. Any questions?
Any questions?
That cleared it out.
Go ahead.
So have you heard from any hospitals that they prefer this not happen?
I have not heard overall from any hospitals that this not happen. I will say what this enables hospitals to do is decide on their own whether or not this should happen. So
That's
they are
correct,
able
that's
to
right.
do, right, so they are able to do, if they want to make it more restrictive, they can say, no, you need to be supervised by a physician or something like that. They can make it more restrictive. This would give them the flexibility for it to be current practice and less restrictive. And then hospitals can make the decision from there, which I think is the right place for the decision to be made.
Any questions?
So
I was almost at a share.
I just looked, APRNs can open up a practice on their own.
After they get this
After,
2
yeah,
years,
it's like
24,
24 months,
yeah, 24,
okay.
yes,
But a PA would not be able to do that.
correct. But in the hospital
But
space,
yeah,
doesn't
hospital
really matter.
setting,
Yeah.
it's up to the hospital if they give them the authority
Mhm.
to do anything, in the emergency room, admitting and discharging
Yes,
and all that. So that's up to each hospital.
yes. Well, and the law.
In the context of the law.
Okay, so what about liability part there?
I don't think this changes the liability
It doesn't,
piece.
okay.
Yeah. I'm thinking of Jessa also. Yeah, that could be.
Sure.
I'm
sorry, Jessa.
No, the only thing I'd say on the liability side is I don't know the answer because I don't know if the physician, current statute requiring a physician to.
Not liable for the PA.
Not for the PA, no, right, not, doesn't change for the PA piece directly, but just for the admitting and discharging. If the physician on paper is currently the admitting
Right.
and discharging provider, I believe that physician
That
Would be
here
liable.
is that liable for
Okay,
that
yep,
outcome
yep,
from that
okay.
admission.
Right.
If that becomes a PA or APRN, I don't think it matters which one of
Right,
those two,
right.
they now then would be liable for those.
Okay, that's
actions.
what I was asking.
So it could potentially reduce liability
It could.
for physicians.
Physicians, but added liability to the PA.
And I honestly think it's a pretty small distinction.
Yeah, I think it is too.
APRN
Could be the hospital,
already-
right?
It's already.
The hospital's definitely liable every time.
And remember, it's the hospital that's holding the liability
Yeah.
insurance on every.
Yeah.
And the physicians and PAs already have malpractice coverage, I think, and they're already providing inpatient care, so I think it's it's probably a small distinction,
Yeah.
I think there may be a distinction.
Yeah, that's right.
Okay,
Okay,
now you can tell it.
Thank you.
thank you. Thanks, Devin. Let's take we take a 15-minute break. Oh, no, wait. No, not 15 minutes. I'm sorry. Let's take a 5-minute break.